Welcome to the Falcon Pathology Review for USMLE Step 1, the second part of the head and neck lecture. Here we will cover larynx, ear, neck, and tumors and other entities of the salivary glands. Laryngoepiglottitis can often be a medical emergency, particularly in children who are affected with a Haemophilus influenzae. Other entities can also be involved here, such as beta hemolytic strep. The sudden swelling of the epiglottis and vocal cords can be a medical emergency and lead to the need to intubate the patient before any further intervention is required. Croup, or laryngotrachobronchitis, as it's referred to clinically, simply refers to inflammatory narrowing of the airway, which produces a classic inspiratory stridor. There are various benign tumors and reactive conditions that can occur to affect the larynx. Perhaps one of the most common are what are referred to as reactive nodules or vocal cord polyps. These are smooth, rounded, sometimes sessile, or even pedunculated lesions that appear within the vocal cords. What one sees when one looks at them histologically are polyps covered with squamous epithelium that can be keratotic, hyperplastic, or on occasions even dysplastic, that is, premalignant. When one looks at the cord of the nodule, you see a collection of loose myxoid connective tissue that can be fibrotic or possibly punctated by numerous vascular channels. One of the other ways in which these polyps are referred to as possibly as Singer's nodes, or for those of us who've dealt with recalcitrant children, as screamer's nodes. Anyone who is putting excessive stress on their larynx and vocal cords is prone to the development of these particular polyps. Carcinoma of the larynx is manifested often by persistent hoarseness, which then, as the tumor develops, goes on to produce pain, dysphagia, and hemoptysis. This slide here shows an example of laryngeal carcinoma. The larynx itself has been inked black and then opened along the posterior aspect. You see a tumor here which is affecting both the true and false vocal cords, and from its ulcerated appearance may have actually spread through the wall of the larynx. Squamous papilloma and papillomatosis, these are benign neoplasms of the larynx. As the name papilloma implies, the picture here is similar to what one might expect when one sees papillomas elsewhere in the body. That is, you can have multiple slender finger-like projections with a central fibrovascular core surrounded by a typical stratified squamous epithelium. Here again, as elsewhere in the body, there is an association with the human papillomavirus. However, the association for the squamous papilloma and papillomatosis here in the vocal cord is with the more benign versions of this virus, such as HPV 6 and 11, not the more malignant forms of the virus associated with things such as cervical cancer, types such as HPV 16, 18, 31, and 33. This now brings us to the ears and the various disorders that can affect this organ. What we need to concern ourselves with here, first of all, are the infections and inflammations, such as acute and chronic otitis media. We will then deal with some of the hereditary conditions that can affect hearing, such as otosclerosis, oral polyps, labyrinthitis, which not only can affect a patient's hearing, but their balance as well, and then some of the tumors that are seen in this region, such as the carcinomas and paragangliomas. Otitis media should be common to most of you, particularly those with any clinical experience. The causes are many and varied. Similar to when we're dealing with pharyngitis, the main concern here will be trying to distinguish whether the otitis media is due to a bacterial cause, the agents often being things such as strep pneumoniae, H. flu, beta hemolytic strep, etc., and the patient thus needs to go on antibiotics, or being due to a viral cause of some type, and thus a watch-and-wait approach can be taken. For patients who have recurrent bouts of otitis media with breakdown of red blood cells and breakdown of cellular membranes, they can have the development of a particular lesion known as cholesteatoma. These are cystic lesions that can range anywhere from 1 to 4 centimeters in diameter, which when one looks at them histologically are lined by keratinized squamous epithelium and contain the classic, somewhat diamond-like spicules of cholesterol that come from the breakdown of cellular membranes. Otosclerosis is a condition where there is abnormal bone deposition in the middle ear around the rim of the oval window where the footplate of the stapes usually sits. This will tend to affect both ears and eventually leads to marked hearing loss. Now to the neck. There are various benign cysts which can affect the neck, but which can lead to great confusion both for clinician and patient, with concerns that a more malignant condition, such as a possible thyroid carcinoma, has developed, and which leads to the need for a pathologist to become involved to biopsy the lesion and determine what type of lesion is actually present. The first of these benign cysts is the branchial cleft cyst or lymphoepithelial cyst, as some authors refer to it. This, as the name implies, is a lesion that arises from remnants of the brachial arches. Usually, in terms of location, this tumor appears on the anterolateral aspect of the neck, a useful fact to remember when one is looking through the stem of questions to try and determine what you're dealing with on USMLE Step 1. These cysts will generally be well circumscribed. They'll have nice fibrous walls lined by stratified squamous epithelium and often with an intense lymphocytic infiltrate. The cyst contents can range from clear watery to a more mucinous fluid, or possibly one that contains the desquamated remnants from the surrounding squamous epithelium and a large amount of granular cellular debris, similar to what one might expect to see, say, within an epithelial inclusion cyst. Thyroglossal tract cysts are remnants of the developing thyroid. This produces cysts that can be lined by stratified squamous epithelium or pseudostratified columnar epithelium. In terms of tumors, the classic one that one thinks about here is the glomus or carotid body tumor, which is essentially just a paraganglioma that appears paravertebrally or within the great vessels of the head and neck. Usually these arise later in life, around the 6th decade, and you can see them in particular in individuals who are affected with multiple endocrine neoplasia or MEN type 2 syndrome. Now, the salivary glands. Again, inflammation is going to be our first topic to deal with here, referred to when it occurs in the salivary glands as saladinitis. Like rhinitis or otitis media, the infection here can be bacterial or viral or even autoimmune in origin. Mumps is a particular infection of the parotid gland that can lead to concerns about infection elsewhere in the body and possible complications such as sterility. An autoimmune disease that can affect the salivary glands is things such as Sjogren's syndrome, which presents with a triad of xerostomia, or dry mouth, a particular form of conjunctivitis known as keratoconjunctivitis sicca, and Michelwitz syndrome, where you have salivary and lacrimal gland enlargement secondary to inflammation with accompanying dry mouth. Patients who are treated for squamous cell cancers of the head and neck can also develop inflammation of the salivary glands due to their use of radiation in this area. And various drugs can also produce saladinitis, including some of the more common antihistamines and phenothiazines. And bacterial causes of salilothiasis and non-specific saladinitis include infections with Staph aureus and Strep viridans. This often follows obstruction of the orifices of the salivary gland either by impacted food debris or edema. In terms of salivary gland neoplasms, there are a couple that you'll need to know for step 1. The first rule to remember is that the likelihood of a salivary gland being malignant is inversely proportional to the size of the gland. Thus, the larger the gland, the more likely the tumor is to be benign. The smaller the gland, the more likely it is to be malignant. One of the most frequent tumors, indeed the most frequent salivary gland neoplasm, is the pleomorphic adenoma. And here, there's a particular group that tends to be more affected by pleomorphic adenomas, and that is women in the age range of 20 to 40. So if you have a question that presents in the history as a woman between the ages of 20 to 40 with a firm, non-tender parotid mass, start thinking of a pleomorphic adenoma. When one looks at these, you see generally well-demarcated masses that are rarely more than 6 centimeters in diameter and which are encapsulated. Histologically, what you will be shown, or what may be described for you in the question, is a tumor that shows a mix of epithelial and mesenchymal elements. Hence, some authors also refer to the pleomorphic adenoma as a benign mixed tumor. Again, your presentation is what one would expect for a relatively benign tumor. A painless, slow-growing, mobile, discrete mass within the salivary gland that appears generally within the parotid gland or possibly within the submandibular areas of the buccal cavity. The problem of the pleomorphic adenoma is that while it is benign, it tends to recur after resection. and surgeons are often limited in how much of the tumor they can resect because of the proximity of the facial nerve. Warthin tumor also goes by the name papillary cystoadenoma lymphatosum. It also arises within the parotid gland. It is a round to oval encapsulated mass, usually within the superficial parotid gland, and is usually benign. Other tumors that one can see within the salivary glands are the mucoepidermoid carcinoma. As the name implies, a combination of squamous cells, mucus-secreting cells, and hybrid cells that appears to fall somewhere between those two. These can appear to be well circumscribed, but actually, unlike pleomorphic adenomas and Warthin's tumors, lack well-defined capsules and are often very infiltrative at their margins. The adenoid cystic carcinoma are small, poorly encapsulated lesions that unfortunately are known for their invasion along the local nerves and thus are often diffusely infiltrative by the time they appear in the salivary gland and lead to a very painful death for the patient. And that ends this section of the Falcon Pathology Review for USMLE Step 1, Head and Neck.